Alright everybody, my name is Dan. Welcome to my presentation. So I'm presenting on musculoskeletal injuries and mixed martial arts. So let's start with the risk factors. Gender. This has a relatively high amount of effect on your risk of injury. So boys count for overall higher amounts of injuries, but women and girls count for a higher ratio. What that just means is guys tend to participate in martial arts more often, but women get injured more for the amount they participate. Younger athletes were less likely to suffer from injuries than athletes 18 and over. Probably has something to do with being a kid. You're going to be at lower level, and you're not going to be performing as dangerous maneuvers. Also, kids are just very tough, is the easiest way to say it. Anyone who's ever been around children and has ever taught children anything know that they can probably get hit by a car half the time and get up as long as you don't make a big deal out of it. Weight. Heavier martial artists are more likely to encounter overuse injuries of the ankle and foot, right? The increased amount of pressure, especially with barefoot training, which is what the article actually goes into, is going to lead to increased amount of tendinopathy, plantar fasciitis, different kinds of overuse injuries with the foot. Of course, it goes without saying that exposure is going to lead to higher amounts of injuries. The longer you do something, the more likely you are to kind of see an injury come from it. This occurs with just about every activity in general. So higher ranks, people with over 3 years of experience are going to have about double the risk of getting an injury. So are people who train about 3 hours a week. And then style. Not every single style has the same rule set. Some of them do heavy sparring, some of them don't. Taekwondo uses a lot more legs than some other styles, so of course you're going to have more leg injuries. Something like boxing or karate that does punches to the face are going to have like maxillofacial fractures. Grappling, so like Aikido and Judo are going to have more ligament injuries because the strange amount of positions you put in creates a lot of stress and strain on the ligaments. So the common musculoskeletal injuries I'm going to be covering is going to be an anterior cruciate ligament sprain, basically it's an ACL tear, a glenohumeral dislocation, shoulder dislocation, shoulder comes out of place, probably seen it. Rotator cuff pathology, this just means the rotator cuff tears. There's 4 different muscles, the teres minor, the infraspinatus, subscapularis, and supraspinatus, and all of them, because the general positions you have to put them in for martial arts, are likely to be torn. So let's start with the ACL. This is when it's stretched or torn, and there's 3 different grades. Grade 1 is going to be the ligaments are stretched but not torn. So have a bad time where you cave in your knee just a little bit of a pop, but relatively stable, just some pain. It's probably going to be a grade 1. It's a little bit stretched, painful, probably recover in about 4 weeks. Grade 2 is a little more severe, so when we start getting to surgery as an option. It's not always necessary, but athletes tend to get surgery more often for a full recovery. This is when there's a partial tear. That's actually, on the left-hand side, would be an example of a partial tear, like in the picture. The right-hand side would be a complete tear, or a grade 3, and that always requires surgery if you intend on getting back to the original sport. This happens when varus forces increase due to various stresses. So basically the knee's going to cave in, and often there's going to be typically rotation going the opposite way, so you kind of have this mismatch creating a lot of stress and tension over the ACL until it snaps. They can only stretch so far, so something to keep in mind is that muscle stretches way further than ligaments or tendons, which is why the first thing generally to tear is actually going to be a muscle. Mechanisms, quick pivoting moments. So football, soccer, we see this a lot. People quickly do a turn, do a pass, or to run, or their knee caves in. That's when you're going to hear that loud pop and see that ACL injury. Unusual leg alignment when you land. So in basketball, I think the examples on the right-hand side, they land with that varus for their knee, and it's going to cause a lot of stress over the ACL. And then knee joint manipulation jiu-jitsu, so a heel hook basically is when you get their heel here, and then you're twisting while stabilizing the femur, So this is going to create a varus force while having tibial torsion. For assessment, we use the Lockman test. Is, as it says here, this is basically just to check for tibial translation, because when the leg is straight and the hip straight, we want to see if the ACL is doing its job, which is normally in this position, would be to prevent the tibia from doing anterior translation or moving forward. We also need to assess both legs. You don't just do one, because maybe someone has looser ligaments than another person. It's just all about unique anatomy and physiology. So we have to compare it to the uninjured side. Common treatments. In the acute phase, we're going to see the Rice protocol. We actually use the police protocol now. I think it's protect, optimally load, then it goes into ice, compress, and elevate. Rice is a bit outdated, but it's still used in a lot of studies. And then there's NSAIDs, or non-steroidal anti-inflammatories, like ibuprofen, naproxen, that kind of thing. And this just reduces the inflammation in the area and reduces pain. Surgery is going to be a less conservative treatment. It's going to be using allografts or autografts. Allograft would be like a graft from a cadaver. An autograft would be a graft from a different ligament or tendon on your own body. So the autografts, they go between patellar and hamstring. Patellar tends to be, I think, a little bit stronger, but is more likely to lead to anterior knee pain. Hamstring tendon is going to be a little bit weaker, but there's not a lot of complications when it comes to permanent pain. And both are pretty efficacious. There's no real no issue from a structural perspective. And then, of course, physical therapy always restore function of the limb. This is with or without surgery. Now, for preventative exercises, we have a lunge and a split squat as a progression. This helps aid with stability and overall muscular control and development. So you want to strengthen the surrounding musculature to prevent just about any injury. The more force we have on the muscle and not on the ligament or tendon, which, like I mentioned earlier, has less elasticity, the better. Same thing with joints when it comes to something like osteoarthritis. We want strong muscles. They can take more force. They can stretch more. A single leg hop, basically you just jump up on one leg. This helps with the stabilization aspect of the ACL and the muscles involved, so the dorsiflexors, right, even plantar flexors eccentrically, as well as the quads, hamstrings, everything has a stabilization aspect. Right, these are just videos demonstrating it. Okay, rehabilitative exercises. So we have a passive knee extension. Passive, whenever we say passive in physical therapy, just means without the use of the muscle directly, but with the aid of an outside force. So in this case, you could do it either with your own hands, or you have manual therapists. They could be the ones moving it through, but we're just moving it through a range of motion. This helps keep it from getting kind of locked in or locked up where it won't move. Active knee extension, same thing, but you're using your own muscles for it. And then we also have heel raises, or calf raises as they're called by most people. And it just strengthens the surrounding musculature and the stability. If you do a single leg, it's even more stability involved. And more demonstration. Here, glenohumeral luxation is the next injury, so shoulder dislocation. This happens when the humeral head is dislodged from the position of the glenoid cavity. This is a very unstable joint. The glenohumeral joint is the most unstable. It's the shoulder joint. So it's only held together by an anterior and a posterior shoulder capsule, which is like a series of ligaments and tendons, right, connective tissue holding together. And then we have the rotator cuffs, and then muscles in front as well, like the pec minor, kind of helping anchor everything and take the force. It's also what aids in the movement of it, of course. There's two types of dislocation. Well, there's multiple types of dislocation actually, but the two most common types are going to be posterior and anterior. Anterior dislocation occurs when it pops out from the front, generally due to stretching here or really hard force that makes it move quickly in a hyperextension. And then we have posterior, same thing is going to happen with hyperflexion. That's when it comes out the back from the posterior capsule. And then this can lead to instability in the shoulder permanently, even after it's reduced or basically put back in place, and then inflammation and pain. In my case, it led to a bit of osteoarthritis that alongside the rotator cuff tears, which generally accompany it. Mechanisms: quick jerks that occur during grappling. So if I'm doing like an ippon seoinage or something, when I'm doing a drop shoulder throw, that's going to actually create a lot of traction in a very quick motion on the shoulder, and that could actually lead to a posterior dislocation. But if you fall on it as well, that also leads to not only acromioclavicular sprains up here, but also the shoulder coming out of place. So we assess it through an anterior drawer test. This is just how we check for stability in general. It's not necessarily it's out of place, but this would allow us to see, is it likely to come out, or has it come out in the past? Especially if it's a subluxation, it's not going to be still out. You're going to have to check the stability. If there's excessive movement of the joint whenever you apply the different pressures, then that's how we get a positive test for instability. For common treatments, again, same thing. RICE protocol, such as police, anti-inflammatories, and then reduction is a new one, but that's basically just the fancy term for relocation. You have to move the joint back in place, and because you obviously don't want the joint out of place, it's very hard to use that way. And physical therapy, as always, it restores the function of the limb. Preventative exercises, we have the chest press. This is going to be a lot of internal rotation as well as strengthening the surrounding musculature. In the case of the progression to a push-up, this actually allows us to control our scapula more, so I like to do a full scapular protraction. Same thing with the chest press, and that allows me to control as it comes down as well. Single arm bent over row, this is going to be more for the posterior aspect, as well as the pull-up. It's just strengthening the muscles back here. We strengthen the surrounding area. Generally, it's going to be a little more stable. Okay. So rehabilitative exercises, we just have isometric internal rotation and external rotation. Isometric being there's no actual movement. You're just exerting force on a stationary object. We have about 12 to 15 reps. It seems like a lot. It's only going to be one set. This is for the acute phase. It actually goes up when we're doing isotonic, which is when we move it. That's probably closer to about 3 sets. This just strengthens the surrounding musculature. So internal rotation is going to be the subscapularis, also some pectoralis major and minor. External is going to be pretty much every other rotator cuff. Alright, so next one is going to be the pathology of the rotator cuff or rotator cuff tear. So this happens when the tendon connecting the rotator cuff is torn. So we have supraspinatus is going to happen during excessive adduction of the humerus. That's basically when it rotates a little too much towards the median or the middle of the body. And then subscapularis is abduction because it's the only rotator cuff that actually does internal rotation. So if this too fast, too much, that's going to tear it. So muscle right in here in the armpit is where the subscapularis is. Infraspinatus, this is the one right in the back, or the infraspinatus fossa. It's, again, excessive internal rotation. This way, generally, is going to cause a tear. And the teres minor is another, it's also used in external rotation, specifically as we use it when we're starting engaging in the pull-up. It's going to be abduction of the inferior angle, so basically if it's coming down too low, and then it comes across. So mechanism of injury, Kimura, Americana, basically they're arm locks that work to tear not only the posterior capsule, but also the muscles surrounding it. Actually, the Americana is going to be this way. That could tear the UCL, that could tear the subscapularis, and even damage the anterior capsule. So this leads to both dislocation and rotator cuff tear. That's why I mentioned earlier that they're kind of connected. Falling and dislocation could also lead to a tear. I haven't seen this as much in my personal life, but anytime you're putting a lot of forces on something and the dislocation itself, that can cause the muscle to pull and tear. And then degenerative issues with tendons, if you have some sort of tendinopathy, specifically I think tendinosis, that's going to cause the tendons to get really weak and make them really easy to tear just by doing any basic movement. Assessment, lateral Job tests. I'll sometimes do this whenever I'm assessing someone to refer them out if I think they might have a tear. Was just how to check to see if they have strength when it comes to shoulder flexion, but also rotation. So a positive test is going to be indicated by pain and weakness. So if they're having trouble getting this up or it just hurts a lot, or even if you don't put any pressure down and they just can't raise it, that's going to indicate a rotator cuff tear most likely. It's very sensitive, but it's not specific, so you don't know which tear it is. With most shoulder assessments, it's kind of a point where anyone with shoulder pain is going to test positive for about everything, so they're not specific. Common treatments: conservative, physical therapy, and then anti-inflammatories. Analgesic just means it's good for managing pain. And then surgical. So if it's severe enough where you either really need the function in it for as an athlete, or if it's completely torn, you're doing arthroplasty. There's also open, though they don't do open surgery as much anymore, but it's surgery where they go in and they reattach the torn tendon. All right, for preventative exercise, we got the overhead press. It's going to be a lot of scapulothoracic control involved, core stability. It's going to strengthen the surrounding musculature of the joint. And then, so the percussion is actually a standing overhead press. So kind of ignore what that says. It's a standing overhead press. It's going to increase the amount of stability required. And then the other exercise is a high-low row. This is going to be the rear musculature specifically. It also engages the lats quite a bit. It's a stretch in the lats. And then the progression for that is going to be a pull-up. For rehabilitation, so it's actually going to be the same as the rehabilitative exercises for a dislocation. Like I mentioned earlier, they're very connected, so it makes sense that they'd be the same, right? If the rotator cuff is responsible for the stability of the glenohumeral joint, then you're going to have the same exercises to rehabilitate the rotator cuff itself as you would for the glenohumeral joint itself. The only real difference is sometimes the amount of pain getting in the way would change, maybe how many reps you do, how many sets, the amount of loading, but for the most part it's going to be the same recommendation. And these are just my references. So I want to make a little caveat here. Osteoarthritis is kind of the subject of my research. It happens when the cartilage in the surrounding joint, the articular cartilage, degrades. So you could have symptomatic or asymptomatic, and in a lot of cases it's going to be symptomatic or it causes chronic inflammation of the joint. And it causes a lot of pain, and it generally results from injuries for athletes, at least, if you're early onset. If you're older, it's just degradation and general wear and tear is what's called as you go through life. But for young people, I think under the age of 50, I think about 70 to 80% of athletes who have had injuries end up getting early onset osteoarthritis. So that's something to keep in mind, is you have to rehabilitate, and you should be following every single recommendation of your clinician if you have any of these injuries, because it could lead to lifelong pain. Well, most days I look fine. I can kick people in the face. I'm still sparring. I also have this for both of my knees, which are a grade 3 degeneration. That means I'm missing about half my cartilage. All right. That's it.